So hi everyone. I'm Troy. I work at the CDC, as Mark mentioned earlier. That exceedingly long bio, which I don't know where it came from, but hey. All right. So here are my disclosures. Not much to disclose in the last little bit. So just a bit of context. I know Lauren has talked about, well, everyone on the panel so far has talked about this, but Canada is currently in the midst of a syphilis epidemic, and that sounds a little bit dramatic, but it actually is true. So syphilis has been a reportable STI in Canada since 1924, and the rates since the turn of the century, and I mean the most recent turn of the century, like the 2000s, have dramatically increased since then, mirroring the rest, pretty much the rest of the industrialized world. And it's really, as has already been mentioned, it's really concentrated, it's a concentrated epidemic in gay, bisexual, and other men who have sex with men. From here on in, I'll be referring mostly to this group as gay men, but it sort of encompasses that whole group. And concentrated in gay men, but also, disproportionately impacting gay men who are HIV positive. And we also know from the data in BC and in other places that reinfection is also very, very common. And syphilis may present even early on in very complicated ways with severe symptoms. So there might be central nervous system involvement, so people can present with neurosyphilis in the first few months of infection. And again, these rates are higher amongst those who are HIV positive. We're actually right now in the process of reviewing some of our ocular syphilis cases because we're noticing a blip. There was last year, there was a report coming out of parts of the Pacific Northwest, well, parts of actually the West Coast in the US, the whole West Coast, where they were seeing an increase in ocular syphilis, so syphilis with eye involvement. And we're noticing probably a similar pattern in BC. When we initially looked at some of the data last year, which was hard to look at because it's not captured very well, it didn't seem like there was much of a pattern, but in 2016, it seems like we're seeing higher numbers. Can everyone hear me okay? Is that fine? All right, and some of the, so, if you, not that I get that much media attention, but when media people ask me, why are these increases happening, I usually give, what I think are reasonable answers, a couple of points, and that the quote that's always used is, I don't know. I think Mark can relate to some of those. But yeah, so we really don't know why the increases are happening necessarily, but there are a few reasons. So increased testing, probably part of the reason. Well, no, definitely part of the reason, but not the only reason. And we know from the trends in testing that testing has definitely increased. So if you're looking for something, the more you look for something, the more you'll find it, but it's not the sole reason. Decreased condom use, maybe. We know from the literature that in the last, the trends in condom use in many populations have decreased, but as many people have pointed out, people have not necessarily changed their pattern of behavior with condom use in oral sex, for instance, which we know is a driver of syphilis in some cases. Changing sexual behaviors, maybe. Maybe, who knows. Certainly in some of the HIV pre-exposure prophylaxis trials, the clinical trials, and some of the demonstration projects, so IPREX and PROUD, we've not, when they've specifically looked for increases in risky behavior, if you will, they haven't found it. So they call this risk compensation. They haven't found increases. People argue that it would make sense that if people are using PrEP, they might change their behavior, but we've not seen that pan out in some of the trials that were done. And one of the other very common questions I've gotten from media people in response to the increasing, not just syphilis, but STI rates is, what role is PrEP playing in all this? And PrEP has not had enough uptake, I would argue, in Canada, but certainly not in BC, to be changing trends in the last year. I just don't buy that. So I don't think it's a player yet in terms of increasing the rates. So we've made some changes locally here in BC, but really the status quo right now is not sufficient. There's an urgent need for novel methods of prevention, as well as determining different ways of looking at assessing risk and causation, syndemics being one of them that should be really informing how we're doing things. So the next few slides and the remainder of my presentation is really going to be focusing on some of the research projects that I'm involved in, along with several other people in this room and outside of this room and outside of this province in Toronto primarily, and just really to highlight some of the work that we're doing to try to get to the bottom of this. So So the first study I want to talk about is a qualitative study. And I'll just disclaim right now that I'm not a qualitative researcher and I really don't have much expertise in qualitative research. Daniel Grace is on this grant as well, who many of you probably know. He knows a little bit about qualitative research. And we're really looking at the drivers of the syphilis epidemic. And this is a Vancouver-based study funded by the Vancouver Foundation, but the money's funneled through our foundation at the BCCDC, so I don't really know who to say funded it, but it's all out there. The objectives of the study, and this study actually, we just started trying to recruit last week, and I don't think we recruited anyone, but we're going to try again next week. And the objectives of it are a couple of them. So to assess the knowledge, attitudes, and beliefs of gay men around sexual behaviors, in an attempt to better understand the drivers of syphilis infection and reinfection, which are reinfection, as I mentioned, is a key component of that we think is driving some of this. And also to examine broader systemic barriers, many of the things that have already been discussed, as a determinant of gay men seeking testing, treatment, and information prevention tools for syphilis and STIs. How we're going to do that, first part is a qualitative one-on-one interview, aiming to recruit 25 men, and that's the part we're doing right now. From that, Daniel's going to use his magic brain and along with other people and develop a quantitative survey based on the qualitative information we get, and that'll be administered to 250 men. So that's the plan. This is a 3-year project. We're about a year in already, and we're just starting it. So the next, I think this is very exciting. So shifting a little bit to a more biomedical theme, is this whole idea of syphilis prep. So in short, what that means is, I'm sure all of you know about HIV prep, HIV pre-exposure prophylaxis, taking a pill daily to prevent HIV infection in those who are HIV negative. So syphilis prep is the same idea. So it's the use of a daily antibiotic, so in this case doxycycline, which is an antibiotic that has been around since I think the 60s, as a focused, time-limited intervention to prevent syphilis and infection and reinfection in gay men. So there is, as I mentioned, a clinical precedent for this, so the use of tenofovir emtricitabine or Truvada to prevent HIV. There's also a clinical rationale for this. So doxycycline has been used again for decades for a number of different things, often over long periods of time. So malaria prophylaxis, it's been used for months to, in some cases up to a year to prevent malaria in certain countries where it's endemic. Leptospirosis is another infection that it's also used to prevent, where you take doxycycline weekly, actually. Leptospirosis is in sort of the same spirally family of bacteria that syphilis belongs to. And number 3 is the treatment of dermatologic conditions. So doxycycline, as well as other members of the class, the tetracycline class, things like minocycline, have been used in the treatment of acne for a really long time. So our thoughts about this were really prompted by one study that was published in 2015, referenced here by Bob Bolin in LA. This is just a screenshot of the article. So really it was a pilot study looking at the daily use of doxycycline in preventing syphilis in HIV positive men. Small study, interesting methods, which I'll go through a little bit. So it was a pilot study, 30 men, with a history of greater than or equal to 2 syphilis infections since their HIV diagnosis. And they were randomized to 2 different arms. So one of them was daily doxycycline therapy, 15 received that one, or this other arm called contingency management, which who knows what that means unless I explain it to you. It means basically getting money every time you come for a visit if you remain STI free. So if you come to your visit and you don't have an STI, like, reward. So 48 weeks of follow-up. The participants had regular STI testing along with filling out questionnaires about number of partners, drug use, condom use. And because it was very expensive, they sporadically did some doxycycline levels to check adherence, but it wasn't done regularly. These are really the results, which I hope you can see, but I will point them out. I don't know if there's a pointer here. Doesn't look like it. what this thing is? No, never mind. All right, so I'll just point to it with my arrow here. So what you can see here, again, it was a very small study. It wasn't powered for efficacy. So if you have a study with 30 people, you're not going to be looking for efficacy, really. But what we did see was, these numbers here are the number of visits with the outcome of interest. So the number of visits where an STI was diagnosed. And if you look here, the line where syphilis was diagnosed, you'll see in the doxycycline arm, over the period of time, there were 2 diagnoses versus 7 in the money arm. I'll just call it the money arm. It didn't quite reach significance, but you can see the trend is there. In terms of, then they had this composite outcome of any STD. Well, they call it STD, any STI. And just as an aside, doxycycline does have activity against both chlamydia and gonorrhea. So if you're looking for, it wasn't meant to treat them, but we still use doxycycline very regularly to treat chlamydia. It's not an effective therapy for gonorrhea because there's a lot of resistance, but it still has activity. And if you looked in the arm where they looked at any STD, the composite outcome, you can see 6 to 15. So 15 people in the money arm, or 15 visits in the money arm had the outcome versus 6, and that was statistically significant if you look at the odds ratio here and the confidence interval. That's reassuring. Certainly not definitive, but reassuring. So that really prompted the design of our own study, which we've now designed and applied for funding a few times with some success. So we've received funding from the CIHR. So in the last round of project scheme competition, we received some what's called bridge funding. So not what we asked for, but a small amount of money to do further development work. We've also received a little bit of money from our foundation, and we've resubmitted to the CIHR because it's a big study that we want to do, and we would require a fair bit more money than what we have. So the objectives really are to determine the efficacy of daily doxy in preventing new cases of syphilis, and then there are secondary outcomes looking at a number of different things, which are, you're probably all thinking of these concerns that come to your mind when you think of taking an antibiotic every day, but safety, efficacy for other SDIs, adherence, and the big one is antimicrobial resistance, which everyone has mentioned to me that I've talked to about the study. We also felt the pilot study had some problems methodologically. First of all, it was a small study, but also some of the, having the 2 arms that weren't really controlled were a problem as well. So we really wanted to replicate, not even replicate, redo a study that sort of looked at these things a bit more with stronger methodology. All right, so it's a multi-center study, centers in Vancouver and Toronto, 15 months of follow-up. So really, it would be for 1 year, and then giving that 3-month lag time to catch those infections that would occur in the incubation period. So as many of you probably know, the outer limit of the incubation period for syphilis is about 90 days. So if you wait about 3 months from last exposure, then you should catch the diagnosis if it occurred 90 days before. So the inclusion criteria, pretty simple. So adult males, sexually active in the last year and planning on continuing to be sexually active, and no point doing this in people who aren't having sex, HIV positive, and then at least 1 syphilis infection in the last 3 years. Hoping to recruit a lot of people, so 318 participants. That's just our study. I've already talked about all these details, but that's just our study sort of timeline. And really, again, recognizing a lot of the concerns that people have when it comes to taking a daily antibiotic. We've really, especially with our resubmission to the CIHR, we've really focused on addressing some of the concerns people have had. So we've put a number of quality interventions in place. So adherence monitoring, measuring adherence in 3 different ways. So there's going to be a questionnaire at each visit, pill counts at each visit, though it's very expensive, we've budgeted for a fair bit of doxycycline drug levels to, again, check to be sure, because, not that we don't trust people, but people don't always tell the truth. So, blood doesn't often lie, so we were planning on checking the doxy drug levels as well. And then really, in terms of looking for antimicrobial resistance, which is people's greatest worry, again, we have a lot of experience with doxycycline. over the years, like I said, decades of use, and there have been small studies that have looked at the impact of that use on resistance, but it has never been looked at in a very comprehensive or prospective way. So we're really hoping to do that here. We have a number of different mechanisms to do that. We're going to do throat swabs or nasopharyngeal swabs, looking for common organisms, and then following, if we find those organisms, so you can have staph or strep hanging out in your nose. If we look at the resistance patterns of those bugs over time and they change specifically to, if the resistance is increasing to the doxycycline class of medication, then we know it's probably having an impact on resistance. And then there's some more complicated molecular stuff that people in our lab are doing that I'm not even going to try to describe to you, but it's happening and it's really fancy and expensive. And then the third study that we've had funded, actually, we just haven't seen the money yet because we're caught up in some contract REB stuff, is called, it's a long title, but if any of you know Mark Hull, he called it the Dudes Trial. I think it's kind of a cute name, but it's combination HIV and syphilis PrEP. So HIV negative men, gay men, will receive tenofovir emtricitabine, or Truvada, along with doxycycline to prevent both HIV and syphilis. It's a feasibility study, and because, again, tenofovir emtricitabine is so expensive currently and not really available, this is a feasibility study, so it's small. It's funded by Gilead, though we don't know where the money is going to land yet. And it's a prospective observational pilot study to evaluate the feasibility of using these two agents. So all participants, so there's 50 participants total, all participants will get tenofovir emtricitabine for 1 year. Half will get doxycycline for a whole year as well, and the other half will get doxycycline for the last 6 months, so deferred, and that 6-month period where they're not getting doxycycline will be our sort of control period for the doxy. The objectives, again, are really feasibility, tolerability and adherence, looking at sexual behaviors as well, and then just looking at incidence of these infections that we don't expect, again, to see much in the way of that because the numbers are so small. All right, and that is it for me. Here are my acknowledgements, and thanks for coming by.